very often orthopedic things, as you can see on our casualty days, how many things which come, both minor and major orthopedics. Trauma, once I will do over the next 2 lectures. Today I will start with called orthopedic things, which is non-trauma. There is a overlap always with rheumatology. So you have some exposure to rheumatology in your medicine and appointments. So this has a bit of overlap. So I know there are mixed areas, but it's better for you to have a thorough understanding of these orthopedic conditions from the medical point of view as well as surgical point of view. Right? So how many have logged in now? Shall I start? Hello? Can I start now? Can you hear me?
Yes, we can. Yes.
Okay, you all can. Okay. If there's any problem, just tell me. So I'm going to start this now, right?
All right, sir.
Okay. So first about orthopedics, this man's name comes up, Graham Apley. He is known as father of modern orthopedic surgery, and this is the hospital St. Peter's, Chertsey, London, Surrey, where he has worked. So he has developed many operative techniques, many examination techniques and all that. Graham Apley's name. So not surprised that we are following his book mainly for orthopedics. And for what he said as described as Apley's triad is examination of any joint, look, feel, move. So you look for any deformity, discoloration, scars, and feel for particularly evidence of acute inflammation and joint tenderness and nature of any swelling. Right? And then movements, first passive, then active, always passive movements, always active movements is wrong. What I have written is wrong. It's first active movements first and then passive, because you must let the patient do what he can, and then only you try your hand, because otherwise things can be more painful. So look, feel, move is Apley's tried for any joint, but there are special tests, and these were later additions. There are special tests for joint, of particular joint. You will come across them as you go, like McMurray's test or straight leg raising test for knee, and drop test for shoulder. So many things depend on the joint. So you must always think when you are examining joints, what are the special tests for this particular joint? And then you have to examine things above and below that joint, other joints, then the general alignment and the soft tissues, as well as any neurovascular and tendon movements related to that limb. So we'll start with the question. You may have done a little bit of reading about orthopedics before. So I want one of you to answer all 5 questions. Don't just try your guesses, right? Carpal bones articulate themselves with hinge joints. Can one of you come in the mic and answer? What do you think?
It's wrong, sir.
Wrong. What is the joint you think they have?
Synovial plane joints.
Yes, they are called gliding joints. Gliding joints. Not in many places you have. It's a tarsus and carpus. You have this gliding kind of joint. And B, Osteoarthritis commonly involve proximal interphalangeal joints. It's a very common thing, osteoarthritis. What do you think? It's distal, and they are called Heberden's nodules, which you see in many old people. I will show a photograph of that later. Then ISED thumb is a feature of rheumatoid disease.
It's true.
It's true. ISED thumb is a feature of rheumatoid disease because rheumatoid disease has a lot of deformities involving the hands. Yeah. And gout does not cause severe permanent deformities.
False.
False, yeah. Both rheumatoid, gout, and psoriasis, they are notorious to cause severe permanent deformities. And dactylitis is characteristic of psoriatic arthritis.
True.
True. What is dactylitis?
Swollen fingers.
Yeah, swollen. Yes, that's right. Because all finger is swollen. Why is it due to? What is it due to? Right, we'll go through the answers now. So carpal bones articulate with themselves with hinge joint as false is gliding joints. But as the distal joints, they are hinge joints, interphalangeal joints and metacarphalangeal joints, they are all hinge joints. And osteoarthritis commonly involves proximal interphalangeal joints, and they are called, I'm not sure about the spelling, Heberden's nodes, but proximal interphalangeal joints may also be involved. They are called Bouchard's nodes. So both are features of osteoarthritis. Then ISED thumb is a feature of rheumatoid disease. And so as other famous deformities associated with rheumatoid disease, ulnar deviation and palmar subluxation of metacarphalangeal joints. Then the famous Boutonniere deformity. Anybody know why Boutonniere deformity? How does it happen? How do you explain that?
With the thickening of the extensor expansion?
Not really, actually. The extensor expansion divided into 3 slips distally. So 2 lateral slips on the either side join together, go from the side, join together, and get attached to distal phalanx. And central slip get attached to base of the middle phalanx. Right? You can touch it on you can feel on your finger and see middle phalanx. And then once it gets ruptured, the central slip gets ruptured, the proximal interphalangeal joint juts up dorsally between the 2 side slips of the extensor expansion. So it's like a button coming through a buttonhole. Okay, so that's very difficult to reduce because it's a kind of permanent deformity. So this is a feature of rheumatoid disease mainly, but certain other conditions also can give rise to. And gout cause disabilities, right? Gout, rheumatoid, psoriasis, both all are notorious. And the extreme disability, which can happen in the hand, is called, I'll show you in this, what's called glass holding, champagne glass with a long handle, glass holding position. So hand becomes swollen, fingers become swollen, and like that, just like when you're holding a glass. Dactylitis is, as you correctly said, it is the sausage-shaped finger, and due to swelling of joints and edema of the tendon sheaths. So these names, please, everybody remember, because orthopedics as well as rheumatoid problems are very common, and whatever the field you are in, you will have to practice that. So we'll go to the second question. I want somebody to answer regarding hand movements. A, abduction of thumb is away and right angle to plane of palm. Correct or wrong? What do you think?
True.
Abduction of thumb is away and right angle to plane of palm.
It's true.
True, yeah. It's thumb movements are right angle to everything else. So this is finger flexion, this is thumb flexion, thumb extension, right? And thumb adduction, thumb abduction. So it's right angle. Ulnar deviation is about 20 degrees maximum. Wrist, hand. Like that, it is 20 degrees is true. Dorsiflexion of the wrist is about 60 degrees maximum. Is it 60? It's a bit more than that, about 75. Okay, 75. So it's wrong. And testing power grip involves squeezing 4 fingers of the examiner. How do you check the power grip? Like that. It's two fingers actually, 2 fingers. And circumduction of thumb is affected in ulnar nerve palsy. What is circumduction?
Collection of all the movements, flexion, extension, abduction.
That's right. You basically, if I can show you here, moving hand like that, collection of all the movements. So is it affected by ulnar palsy?
False.
Huh? What do you think?
False.
Yes.
It is affected. Yeah. Why? What is the main
Adductor polysis. Adductor
Yeah.
polysis.
Adductor polysis. That's right. This one, muscle, adductor polysis. Good. So we'll just run through the questions, answers. So ulnar and radial both are about 20 degrees. Dorsiflexion of the wrist and palmar flexion both are about 75 degrees. Okay. So power grip involves squeezing 2 fingers, and other grips you have to see are involved like key grip. You hold the key like that, key grip and pincer grip. They are important things to consider. But when you are checking these finger movements, always better to give a a practical test such as button up a shirt that will give a good assessment of all these movements. Then the circumduction, of course, as you said, the adductor involvement is there. So next question is regarding conditions affecting the hand, right? Conditions affecting the hand. So somebody to answer, please. Carpal tunnel syndromes, most of them are idiopathic. What
False.
do you think? Sorry?
False.
It's true actually. Most are idiopathic, yes. Right? But what are the causes, you know?
Postmenopausal women with osteoporosis.
Yes. People sometimes on contraceptives, hypothyroidism, anything which enlarges tissues or compresses the canal, like carpal tunnel, Colles fracture. So those things can lead to carpal tunnel syndrome, right? Then Dupuytren's contracture usually affect 3rd and 4th fingers. Is it true? Huh? 3rd and 4th fingers?
False.
Yeah, which fingers?
4 and 5.
4 and 5. Very good. Pitting nails are a feature of psoriasis.
Yes, sir.
Yes. Yeah, it's very interesting feature. And polycythemia is a cause for Raynaud's disease.
True. It's true, sir.
Well, there's Raynaud disease and there's Raynaud's phenomenon. What is disease and what is phenomenon? Raynaud disease is a primary thing. There is no cause for that. Okay. But then there are multiple causes which can exhibit etiologies which can exhibit Raynaud's phenomenon. So polycythemia is one such thing, right? There are very many causes like cervical rib and smoking, many about, I think, about there are 15, 20 things, right? In certain conditions like connective tissue disorders, they can all exhibit Raynaud phenomenon. So what is this Raynaud's thing? What is the mnemonic for that? What are the clinical features which occur in somebody who has Raynaud's, somebody who shows Raynaud's disease? WBC, have you heard of that? White, blue, and crimson. The skin undergo those changes. Initially become white due to no blood, then blood gets no blood flow, then it become blue, cyanosis, and then there's reactive hyperemia following that, which make it crimson. Okay. Then prayer sign is useful in diagnosing diabetic chiroarthropathy. You can have this kind of advanced questions to people who read more. Okay. Prayer sign is that you can do
Yes,
this
it is
in diabetic issues. People who have deformed diabetic hands or various problems, you can't do that basically, right? So going through the answers, most carpal tunnel idiopathic, Dupuytren's affect fourth and fifth, pitting nails of psoriasis. Okay, yeah. So another thing for diabetes is called tabletop test, that you keep both hands flat on the tabletop. You can't do that in diabetic arthropathy. So going to elbow, normal valgal position, you know, the elbow, we have a carrying angle, and it's different. In females, it's more, isn't it? Carrying angle of the elbow. Females, it's more, and it's about 5 degrees. Anybody? What do you think? It's a bit more than that. No, if you look at your elbow, it's between 10 to 20 degrees. So it's more in females. Then maximum flexion is about 170 degrees. You can flex your elbow and see. It's difficult to reach 170, isn't it? It's a little less, I would say. I mean, 180 is full. So, but it's about 160, 150, something like that. Rheumatoid nodules appear yellowish under skin. You know, with certain conditions, you can have nodules, particularly at the elbow, right? So rheumatoid nodules appear yellowish under skin. What do you think?
False.
False.
False. What kind of nodules would appear under skin, yellowish?
Gout.
Gout, yeah. So both rheumatoid, gout, and psoriasis, you can have nodules under skin, but yellow ones are due to gout. Tenderness over medial epicondyle is called cricket elbow.
True.
True. Yeah. What is the other name for that?
Golfs.
Golf elbow, yes. Head of radius is not palpable normally. You can rotate the elbow and see whether you can palpate it.
It's false.
It falls. You can palpate it actually. Yeah. You can palpate. What is Henry's method? Have you heard of Henry's method in when you are doing anatomy? Harold Ellis, to locate the branch of the radial nerve, circumflex, moving around. So read about Henry's method of locating the nerve. So normal valgal position is between 10 to 20 degrees. Maximum flexion is about 150 degrees of the elbow. So rheumatoid nodules, it's gout which appear yellow. So regarding shoulder, somebody please answer. Stability mostly depend on ligaments. Is it true?
False.
false.
On what?
Muscle.
Muscle.
Muscles, rotator cuff muscles mainly. Then apply scratch test, exclude need for passive movement testing. Probably you are not familiar with this scratch test, but better to get to know. So it's called apply triple scratch test. You first try to touch the scapula in 3 different ways, right? One here, one over the head, one behind the back to touch the scapula of the other side. So if you can do that, there's nothing seriously wrong with the shoulder movements. So that's a quick test when you are examining patients. Frozen shoulder restricts all movements.
True.
True. What is the technical name for frozen shoulder? Adhesive capsulitis. Okay, it's called adhesive capsulitis. Whole capsule is kind of inflamed or stiff, and then that means all movements are restricted. Positive drop test is due to supraspinatus tendinitis. If you don't know what positive drop test is, I tell you in this finger, you hold the hand like that. And then when you ask to drop it, it just without any control suddenly drops. It's due to supraspinatus tendon rupture, not tendinitis, right? Tendinitis will cause what? Have you heard of that? Painful arc syndrome. They are common names, right? Painful arc syndrome due to supraspinous tendinitis and positive drop test due to supraspinous tendon rupture. So because shoulder problems are very common, and you must know it's a joint which does not tolerate immobilization very much. If you immobilize for 2-3 weeks, you will get one of these various problems like this. Positive cross-arm test indicate acromioclavicular joint disease. So those who know what positive cross-arm test is, you basically cross the arm like that. Okay, like here will produce pain because it put acromioclavicular joint under a lot of stress. It produce pain. Okay, so that is a test to detect acromioclavicular joint problem with the subluxation, dislocation, inflammation, whatever. So these are small tests. These all tests, please remember and use them when you are examining a shoulder joint. I would like you to have a note how to examine a shoulder joint. Basically, look, feel, move. Special test above and below, like we mentioned before. So you have to above and below means above you have to think of the root of the neck and the cervical spine, and those and below the distal arm, neurovascular tendon, nerve lesions, all that should be included. Prepare a small card to examine a shoulder and practice it. So answers as we discussed. So next question is regarding the spine, right? So, spine in the neck, the normal lateral flexion is about 60 degrees, like that. What do you think?
True.
It's about 45. It's not 60 really, 45. Because what happens is we feel it's 60 because we bring the shoulder also up to meet halfway. So, right, otherwise, if you just check the normal flexion, it's 45. Sparling test is 90% sensitive to cervical root compression. Those who don't know what Sparling test is, when we are suspecting cervical root compression due to osteoarthritis or some cervical spine problem, chronic cervical spine problem, rheumatoid arthritis can affect the cervical spine. The patients have this pain on both shoulders and arms. It's a very common thing, pain on the shoulder, girdle, arm, especially elderly people, they come complaining. So there are many reasons which you can have pain. I mean, maybe due to something to do with joints or muscles. And we want to know whether it's due to cervical root compression. So this test, this Sparling test is very Good. Please write down the name and read about it. Basically, what you do is you extend the head and turn the head to this side and bend, flex, right? Extend, rotate, and bend to one side. That will compress the roots and bring about positive pain. It will reproduce that pain you used to have, right? That can be relieved. If you bring the shoulder up, then that pressure becomes less and pain will be relieved. So that's relief element is also important to confirm this sometimes. So this test is very valuable to detect cervical root compression, which is a very common problem in elderly. A very common problem in elderly. Rotation usually occur at thoracic spine.
True.
Rotation, yes, it's at thoracic spine, yes. And the flexion and extension at lumbar spine, okay. Erectile dysfunction is associated with cauda equina compression.
True.
True. There are 4 features, the quadrant කියන්නේ හතරනේ. 4 features associated with cauda equina compression. They are, anybody? Erectile dysfunction, what else? What else? Saddle anesthesia, urinary incontinence or retention, bowel incontinence. Okay, those are the 4 features you must look for and search for in suspected cauda equina compression. Most common origin of back pain is local and musculoskeletal. What do you think? Back pain is again a very common situation. You must know all about it, how to examine and what are the different causes and how to investigate, because some causes are quite sinister, isn't it? Sinister causes like, malignancy, metastasis, or TB, myeloma. Right, let's go through the answers. So normal lateral flexion of the neck is about 45 degrees. So Sparling test, I told you. Rest we have discussed. Now we go to hips. Regarding hips, somebody please answer. Pain radiate to knee. True. Yes. Referred pain. B. Tenderness over mid-inguinal point may indicate inflammation of hip joint. There, in fact, it's true, because hip joint is actually deep joint covered by many muscles and difficult to palpate. But only part of the femoral head which is palpable is that mid-inguinal point anteriorly. It's not directly palpable, but over the muscles, it is palpable. So in the evidence, if there's hip joint inflammation, that pain, tenderness, or pressure on that point will cause tenderness. Because that extraarticular part, hip head is extraarticular there. As you know, it fixes the pelvis from this direction. So that part is extraarticular and it's palpable and tender in that case. So normal lateral rotation of hip is about 45 degrees.
True.
True. Yeah. You know how you do that. You flex the hip at 90 degrees, flex the knee at, extend the, flex the hip at 90 degrees and flex the knee at 90 degrees, and then you rotate that. It's 45 degrees lateral rotation, and the medial rotation is also 45 degrees. Faber test checks sacroiliac joint and hip joint inflammation. I'm giving you names of lot of tests, so please write them down and include them as special tests when you are in your note at how to examine a joint, because look, feel, move, special test, and above and below. That is the way you examine a joint. So under special test, for each joint include this, right? This is FA is F for flexion, AB for abduction, ER for external rotation. So you can do all that together, and leg will end up in like a 4 position. Cross, 2 legs will be like crossed on like that in a position like a 4. Lower limbs will look like 4, 1 leg bend like that. So when you do that, you might get pain at sacroiliac joint and hip joint, both are tense. So if you get pain in those joints, then you know that there's some problem with that joint, right? Trendelenburg test indicate myopathy on the side of non-weight bearing leg. What happens in Trendelenburg? Anybody?
When the weight is given to one limb, the other limb braces about the horizontal plane.
Okay. So Trendelenburg indicate myopathy on the side of non-weight bearing leg. Right? So yeah, you are right. When you are standing on one leg, you should be able to raise the other leg up, right? In this, if you have myopathy on that side, that is side you are standing, what will happen?
The other side will drop.
Will drop. Okay. So test indicate myopathy on the side of non-weight bearing leg, weight bearing leg, ne? Trendelenburg test indicate myopathy on the weight bearing leg. Weight bearing leg එකේ myopathy එකක් තියෙනවනේ අනිත් පැත්ත පහත් වෙන්නේ. එතකොට positive test එකක් එන්නේ. Okay? You understand?
Yes, sir.
Okay, right. So if anybody doesn't understand, please unmute and answer. So answers, hip, medial rotation, lateral, both are 45 degrees, and abduction is about 50 degrees, and adduction is 45 degrees, and extension 30, and flexion is 150 degrees. These figures you must remember when you are examining a joint, because if you don't know what's normal, because you are doing this under short cases or things like that, if you don't know the normal, then you would not know what is abnormal. Okay, so please remember this range, normal range of movements for each joint. So examination of the knee. Now we are going to knee. Somebody please answer. Medial meniscus is more likely to injure than lateral.
True.
True. Why? It's more firmly attached. It's more firmly attached to the medial collateral ligament. Then it can't move about or jump when the pressure comes, so it get torn. Okay, when abnormal pressure comes there. B, lateral instability is tested with knee in full extension.
False.
Yes. What is the correct answer?
Knee flexed in knee flex position in supine.
Well, yeah, it's knee flexed at about 20 degrees. You have to flex the knee at 20 degrees, then only you can check the instability, 10 to 20 degrees, right? Both lateral instability and medial instability, both, right? So that's basically what checking mostly collateral ligaments. Anterior drawer sign is a feature of lateral collateral ligament and medial collateral ligament injury.
False.
False. What is it the feature of?
Cruciate ligament.
That's right. Anterior cruciate, isn't it? Yeah. How are they named, cruciate ligaments? How are they named? anterior and posterior cruciate වලට නම් දාලා තියෙන්නේ කොහොමද?
On its attachment
To
the tibia.
yes, on its attachment to tibia. Tibia, if it attached to anterior part of the tibia, it is anterior cruciate. That's right. So grinding test is done to diagnose loose body. Have you heard of grinding test? It's a special test for knee. You can, when you flex the knee and then extend it while grinding, right? It is to check meniscal injury. If meniscus is torn or something, it will cause pain when you move the knee while grinding. Patient is lying on prone position and you move the thing while grinding. That will cause pain in meniscal tear or meniscal injury. Okay. Loose body would lead to what? Normally, loose body. Locking of the knee. It will, when there's loose body traveling around the knee joint, it will lead to sudden locking. Knee is the most common site for osteochondritis dissecans. Anybody know what osteochondritis dissecans is? It's an important thing that you should know. It's a detachment of the piece of cartilage and bone due to necrosis of the underlying bone. So it's something to do with blood flow become less to underlying bone, and as a result, the more superficial fragment, superficial area lining the joint become displaced. So it's act like a loose body basically, unless you stop it early and rest and doesn't heal it. It happens in adolescents, young people. So going through the answers, medial meniscus is more likely to be injured than lateral. Excuse me. Sorry. So lateral instability, how you check, anterior drawer sign, grinding test, and the osteochondritis dissecans can also occur in elbow as well as ankle. It's common with adolescents who are involved in jumping sports because of the pressure. Some part of the superficial bone and cartilage become necrotic and get loosen. So going to lumps around knee, this is a very common thing, common short case actually, short case to give lumps around knee. Somebody please answer. Tibial apophysitis usually affect teens. What do you think? Anybody? Hello? Can anybody hear me? Hello?
We can hear you, sir.
All right. So this is, what is the other name for tibial apophysitis? Anybody know? Osgood-Slater's disease? Osgood-Slater's disease. So this is basically inflammation of the tibial attachment of extensor apparatus, right? So you know that extensor apparatus is quadriceps muscle, patella, patellar ligament, and get attached to tibial tuberosity. So that attachment, there's some inflammation. This happens in teens following active sports. Management is just rest. It will heal by itself. B, meniscal cysts are more common on the medial side. Anybody? They are more common on the lateral side actually. So what is the management of meniscal cysts? You can leave it, you can aspirate it, and you can operate on it. And so it can recur. Unless you do a proper operation, it can recur, because what happens is due to pressure, there's a various arthritis and various conditions can cause pressure inside the joint cavity, and that extrudes the fluid, a synovial fluid, out through the meniscus. So but it can recur if you just aspirate, because that hole you have to close surgically. Okay. Prepatellar bursitis is called clergyman's knee.
False.
It's called whose knee then?
Housemaid.
Housemaid's knee. Yeah. So clergyman's knee is what?
Infrapatellar bursitis.
Infrapatellar bursitis. Yeah. So Baker's cyst usually communicate with the joint. Baker's cyst.
True, sir.
True. Usually communicate joint. It's like a degenerative condition. It's a herniation of the synovial membrane or synovial cavity, and it happens in elderly people with osteoporosis. And actually, when you examine Baker's cyst, what happens is when you flex the knee, that pressure is not there, so it will reduce. That fluid will go into the joint cavity. When you extend or stand on that, the cyst will appear. That's the important diagnostic point. So these things sometimes can rupture and lead to calf tenderness. Swelling can come down, blood can come down the calf and cause calf swelling and tenderness, which comes under differential diagnosis of deep vein thrombosis or other causes of unilateral leg swelling. Right? Semitendinosus bursae appears on the posterolateral side of the knee.
It's medial.
Yeah, it's medial. That's right. So you get it's semitendinosus. Semitendinosus is on the lateral side, isn't it? Semimembranosus. The membranosus is on the medial side. Let's see. Yeah, sorry, you're right. Semitendinosus on the posterolateral side, yeah. Baker's cyst is a pressure diverticulum. Yeah, that name please remember, because that's most common type of apophysitis. That is epiphyseal inflammation seen in the body, Osgood-Schlater's disease. Meniscuses are common on the lateral side. 20 to 40 years are the typical age group which are active and cause pressure inside the knee joint. So going to foot, anybody please answer. Gout usually affect first metatarsophalangeal joint. True. Yeah. So what is the other DD? If you see a red inflamed metatarsophalangeal joint, other common DD which comes to your mind? Bunion. Bunion is an inflamed bursa attached on that surface in that area, which is associated with hallux valgus deformity of the rheumatoid arthritis. So that also can be inflamed, and it's also look red and swollen, just like in a gouty joint. What are the things which precipitate gout?
Beer, alcohol consumption.
Yes, alcohol. So it's very common after party, a morning after party in prone people. You can get that. What are the tests you do if you suspect gout? Normally that's how the first attack presents, right? May joint involved. You would do serum uric acid, then you do aspirate the joint and examine these crystals. Under polarized light, they show some particular difference. And then you treat acute condition with Voltaren, non-steroids. And long-term, what is the treatment for gout? To reduce uric acid level in the blood?
Allopurinol.
Yeah, allopurinol. So next question. in diabetic, flattening of longitudinal arch is more common than claw foot. You know, diabetic foot is a special subject. You have to know a lot about that, diabetic foot and diabetic ulcers, both for medicine as well as surgery. Diabetic affect the vascular supply, it affect muscles, it lead to the atrophy of muscles, wasting of muscles in the foot, small muscles, I mean. Then it lead to for neuropathy, and it can deform the joints, right? Ultimately, you end up with Charcos joints, severely deformity of the joints, and abnormality like claw foot and flattening is more common. So flattening is more common really. Flat foot, that is because the foot was normal like that and become flat because of the wasting of the muscles, and the ligaments also become weaker, right? And joint distortion. So flat, it becomes flat, and as a result, pressure points are different. So you develop callosities and wrong places, become ulcers, infected. Ulcers become deep, it goes into bone and cause chronic ulcers, osteomyelitis, ultimately ending in amputation. So you must understand how diabetes affect the foot and what are these changes which cause. Sometimes you have fat foot that's called pes planus. Sometimes you can have claw foot if the contracture of muscles and tendons occur. Sometimes you have arch foot like that. Okay, arch foot like that. That's called rocker bottom feet. Rocker bottom feet. Rocker bottom කියන්නේ අර පොඩි ළමයින්ගේ තියෙන්නේ මේ අර අස්සය ඒ වගේ. So when it's rocker bottom feet, it's in the middle of the foot, get abdominal pressure, and you have develop ulcers there. Callosity soon become ulcer. Ulcer soon become deep and osteomyelitic. That's what you have to avoid. So special footwear is very important. Diabetic control, early attention to wounds. So it's a very common social problem. Rupture of Achilles tendon is common in 30 to 40 age group.
True.
What do you think? Most of the fast bowlers were in their prime, like Malinga or Was. They are in this age group, no? They won't get Achilles tendon. No? It happened in slightly older age group, 40 to 50, 55, especially who try to do exercises out of fear for heart attacks or things like that. Then they get this Achilles tendon rupture actually. Little older than this, okay? This is the prime age. Heel pain in a rheumatoid patient is usually due to subtalar arthritis. Rheumatoid patients, like diabetic patients, can have pain in the feet due to many problems, right? They also can have. But more common with rheumatoid patient is soft tissue things like plantar fasciitis causing pain than arthritis, right? Arthritis takes time. E. Morton's metatarsalgia is due to impending stress fracture. Anybody? Morton metatarsalgia is actually neuromas of the feet, interdigital nerves, neuroma. And it's like when you put the foot or when you're running, you feel like current is coming from the foot. Like, okay, you get electrocuted like feeling. That's due to trauma, running athletes, military recruits. So it's a painful condition. So you may have to give steroid injection or do things like that. Morton's metatarsalgia. But stress fracture also happens in same people, similar people like athletes or military recruits. Then what happens is you get pain in the feet, you do x-ray, and you can see some callus developing around the metatarsal at particular points. So what you do is you have to rest them for 3 months. Then no running, no activities for 3 months, and then they will recover that from that stress fracture. The answers. So ankylosing spondylitis compared to other seronegative arthropathies has, right? So you know what is seronegative arthropathies? It's a group of conditions which are rheumatoid factor negative, right? How many rheumatoid people have rheumatoid factor positive? How many people with rheumatoid disease? Percentage wise, anybody? Can anybody have a guess?
70%.
Yes, you are correct. 70%. Okay, 70% have rheumatoid factor positivity in them, and then you have other people are called those with zero negative arthropathies. They are the other group. It's a collective conditions. So, what are the seronegative arthropathies? Tell me. Ankylosing spondylitis, Reiter's disease,
Psoriatic arthritis.
Reactive arthritis,
reactive arthritis, and
crystal arthritis.
yeah, and enteropathic arthritis. Yes, those are the group of conditions. So ankylosing spondylitis compared to other seronegative arthritis has iritis, correct? It's true. About 10 to 15% of them have. Others also it can happen, but it's rare. Urethritis, false. Now, which condition it has? Urethritis. You must think of what are the other conditions. I'm doing comparison here. Right? Yeah, right. Yeah. Nail lesions.
It's
Are more common in which one?
Psoriatic arthritis.
Yeah, that's right. And involvement of the knee joint. False, isn't it? Because seronegative arthritis affect the axis, main axis, right? Central things, central joints. Straight spine on X-ray.
True.
Huh? Where you get that? In which one?
Ankylosing spondylitis.
Yeah, that's right. Ankylosing spondylitis. So let's see. Answers. So if the knee joint is involved, you have to think of rheumatoid and osteoarthritis more than that. So regarding arthritis again, leukemia is a cause of gout.
True.
Yes, secondary, secondary gout. You have a primary gout disorder, then secondary gout due to leukemia, so other malignant conditions, particularly following chemotherapy or things, you can get that. So it's a cause. So gout, which is secondary gout actually in this case. Butterfly rash is a common feature of mixed connective tissue disorder.
It's true.
True. Yeah. What is the main condition which give rise to butterfly rash?
Systemic lupus erythematosus.
Yeah. Renal failure is the most common cause of death in CREST. Hypertension, severe hypertension and renal failure is common in scleroderma. It's usually most common cause, but the pest has many other problems which can kill a person. So edema and swelling of hands is common in mixed connective tissue disorder. True, yeah. Fibromyalgia typically affect girdles. Girdle mean, shoulders and hips.
It's true.
Well, typically affect the spine, neck and the back. Girdles, not the girdles normally. Girdles get affected by myopathies and like thyrotoxicosis, diabetes, those things. So when you say typically affects, that word is being the operative word in this MCQ is typically. So let's go. So leukemia, butterfly rash I have put it's a feature of SLE, but recognized, which I think it's correct. What you said is true. It's a recognized feature because MCTD has SLE features as well. So when you say recognized feature, even if it is rare, very rare, or extremely rare, it can still be correct. So it's correct. What I have marked here is inappropriate. So renal failure is common cause, most common cause of death in scleroderma. So other thing is this MCTD, mixed connective tissue disorder, edema and swelling of the hands are very common. In over 50%, they have that, right? Over 50%. And myositis occurs in 1/3, and esophageal motility problems in almost 50%, right? Esophageal motility problems, functional problems of esophagus. So, I mean, this group of conditions, I know our knowledge is fairly limited on this. We don't read much and we don't think about them, but they are much more common than they think, particularly this fibromyalgia, right? Particularly this fibromyalgia is a very common situation than we think. We don't diagnose them because when patients come, we put them to various musculoskeletal problems or age or, what you call APR syndrome and don't think about these things. But many of the things we dismiss, give some Panadol and dismiss, they can have this connective tissue disorder. So I think whether you are a surgeon or physician, the patient comes to anybody, you have to think more often. So you have to read more often about their features and things. I myself read little on this line, but I have to read more. So regarding lab investigations for patient with arthritis, right? Anticyclic citrullinated peptide, anti-CCP, is more sensitive than rheumatoid factor for diagnosis of rheumatoid disease. Correct?
True. True.
Well, they are equally sensitive. Okay? They are equally sensitive, but this is more specific. Anti-CCP is more specific. So all developed countries now, instead of rheumatoid factor, they do anti-CCP because that's more specific. While rheumatoid factor can be positive in many people who do not have rheumatoid disease. So anti-nuclear antibody is positive in scleroderma. ANA.
True.
Anti-double-stranded DNA specific, specific ANA is specific for CREST. I know without sharp memory and you have read it, you can't answer, right? It is difficult for me to answer also if I can't remember. And my main thing is that we have to read about these things. We have to get our knowledge and investigation into these things because we are missing a lot of people, a lot of things by not having this knowledge or not brushing up on this knowledge. Joint aspirate is useful in diagnosis of gout. Anybody? Pseudogout. So it's useful in diagnosis of gout, pseudogout, and septic arthritis. Septic arthritis is a medical emergency, as you know. So joint aspirate is useful if you're suspecting any of these things. Urinary culture is mandatory in diagnosis of reactive arthritis. What is reactive arthritis? Anybody tell me what reactive arthritis is?
Usually following a sexually transmitted infection.
Not just sexually transmitted infection. It's a arthritis.
It's immune.
Which is associated with infection somewhere else. Right? It is arthritis which is associated with infection somewhere else. So it's due to through an immune reaction, like mostly cross-reacting antibody. Okay. So arthritis associated with infection somewhere else, which may be sexually transmitted, maybe UTI, maybe diarrheal, or some other, right? So we'll see these answers. Anticyclic anti-CCP is more sensitive, but sensitive equal, but anti is more specific. So ANA is positive in scleroderma, right? It's true, and also in SLE, drug-induced lupus, MCTD, Sjogren syndrome, and things. ANCA, right? ANCA, right? Anti-nuclear cytoplasmic, anti-neutrophil cytoplasmic antibodies present in Wagner's disease. So these tests you must know: ANA, ANCA, and anti-CCP. Things I'm sure you know from medicine, but we better brush it up. So anti-double-stranded DNA specific ANA, because ANA has different types, more specific types, which are diagnostic for individual diseases. So this type of ANA is specific for crest that falls. It is for SLE, right? But anti-U1 RNP type of ANA is specific for MTCD, and anti-centromere antibody is specific for crest. Okay. So to end the lecture, we'll go through a few things. So what is the what is this? What do we see? Huh? Sorry? Can anybody tell me what this is? They are?
Sore neck.
Not sore neck. They are Herbert's nodes of osteoarthritis, right? Herbert's nodes. This is very common. You see a lot of old people have these things, right? Of osteoarthritis. And what is this? This slide. Because of our theoretical knowledge, we must be able to apply for these things, right? What you see prominent metatarsal heads.
Metacarpal.
Yeah, metacarpal. Fingers are at a lower level, right? So you will see subluxation of metacarphalangeal joints, right? You will see the wasting of muscles here, right? So this is basically a rheumatoid hand. Right? It's a rheumatoid hand. So it's a severe rheumatoid hand with some permanent changes. Permanent changes, okay? What is this? Anybody?
Butterfly.
Yeah, butterfly rash, yeah. So it happens in SLE and certain other conditions. And this patient complained of locking of knee at times. Pain, not locking, say pain, and effusion of the knee. Is a young person, a sportsman, club cricketer. You see any abnormality on this X-ray?
Yes, white.
What is the abnormality? No, it's wide. It looks wide here because that is because the joint, the opening, it's at with the X-ray shot. But can you see a small part here? Piece of cartilage and bone about to separate. So this is osteochondritis dissecans. Okay, so that's osteochondritis dissecans. Okay, so we talked about the condition which can affect certain other joints as well, but knee is the most common. It's due to active young people. You get this disease. And this is a patient who has back pain and neck pain, and X-ray cervical spine is taken. What is the abnormality you see here on this X-ray? Anybody?
The vertebra fused.
Sorry?
The vertebra fused.
Vertebra? Yeah. Fused.
Fused.
Yes. Why do you say it's fused? It's fused, it's straight. And you can see this, if fused means there's a calcification here, isn't it? Huh? There's a calcification. This line should not be there. So they are fused, they are calcified. So what do you call that type of spine? Bamboo spine. That's right. So what's the condition? Ankylosing spondylitis. What is the famous gene which is associated with ankylosing spondylitis? HLA
B27.
B27. That's right. Yeah, it's not used for diagnostic purposes because that's not very accurate in that sense. But it is used. So what is this?
Bunyan bursitis.
Yeah, it is Bunyan bursitis. You're right. So as you can see, there is a bit of hallux valgus. Hallux valgus. So when it's vulgar pressure, you develop this pressure, so you develop this bunion. So it's a kind of what you call bursa are two types, no? Adventitial bursa and congenital bursa. So it's more like adventitial bursa, which has developed over the area of abdominal friction, and now it gets inflamed. So that ends our lecture today. Any questions? Do you have any questions to ask? Okay, so we will talk about traumatic orthopedics next time. The next lecture, I have 4 lectures in orthopedics to give. So we will about trauma involving upper limbs in one, trauma involving lower limbs in one, and final lecture I will think of what to do. So please read bit of a please and make a nice note set on these conditions, and proper note set for your exam for your purposes, and yeah, and answer look at many photographs and x-rays. That's the best way to remember these orthopedic conditions. So you must be able to spot diagnose, like when you see these things, it makes you very confident as a doctor. So okay, that's it for the moment. Everything okay with you all?
Yes, sir.
Okay, right. We'll meet next week. So we'll do more and more work through online until things are open, or even after things are open, right? Okay.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Right.
Thank you, sir.
Welcome.
Thank you, sir.
Welcome.